WCLN 1170 Radio and Cable Channel 16 are pleased to present We Should Know, hosted by JW Simmons, an upbeat, informative look at people, places, and issues facing our community. This education-based analysis of issues will remain positive and informative as we consider closely what we should know.
Ladies and gentlemen, thank you for being with us today. I want to welcome you. We Should Know is on there. I'm your host, JW Simmons. Our guest today is Dr. Shawn Howerton. He's a CEO. He's a medical doctor. Sampson Regional Medical Center is his CEO and medical world. Also, private practice in Rollsboro, Howerton Family Medicine in Rollsboro. Many folks know that and depend on it. Dr. Howerton, I think that today's conversation is one of those that we need to have periodically. You've been on the show before. You understand kind of what the format is. When you look at healthcare, when you think about what you do, let's talk about some of the things from the perspective of the hospital area first, and look at some of the things that Sampson Regional is doing, some of the things that you would like to maybe expand upon that is important for a lot of folks to know, because Sampson Regional is, maybe I'll use this phrase, is a survivor in the sense of hospitals in rural areas. Just kind of give us an idea of how that is possible. And you're also running a very strong budget in the world of a pandemic.
So first, thank you for having me on. It's always nice to be able to talk to our community directly, and I appreciate you having the time with me. From a hospital perspective, we're one of, I think, 8 to 12 single hospital rural system, if you will. It gets very confusing because rural health has its own challenges. Rural health and being your own system has some significant additional challenges. And for us, we are one of the larger employers in our community. So we need to be here not just for the health of our community, but also our county depends on us for jobs and employment. Overall, we've managed to balance our budget just like everybody does, hopefully at home. And doesn't mean that there's not tighter times, and doesn't mean that you buy everything that you want, but you make a plan and you stick to it, and you don't spend money that you don't have. For us, one of our bigger things is focusing in on quality. And so if we got to a point that we didn't feel that we could provide quality care to our community, that's when we would really be looking at having a partner. As a rural community hospital, there's things that we will never do in this community, should never do in this community, just from a standpoint that you don't have all the downstream specialists that are here to take care of a complication. So in general, from a medicine perspective, if you can't handle the complications, you really shouldn't be doing it in the first place. Overall, we continue to make that plan and live within that world.
We had a conversation last year, kind of at maybe the first trimester of the COVID event, and we talked about the hospital capacity in dealing with COVID. As we have this conversation, January of 2021, is the capacity still there to be able to handle COVID patients? What percent of critical care beds are available? How does that look? Is it improving? Is it not improving?
I would say that while we still have plenty of physical beds, one of our bigger challenges is while we have healthcare heroes here taking care of people, they're human and they still get sick as well. And so one of our struggles is when they're sick, we can't fill a bed without having the staff there to provide care. And that's not just a Sampson Regional issue. That's across the country right now, and probably across the world. So we have had times where we've struggled with having additional staff. I will tell you right now, while we are better than I expected us to be a couple weeks after the new year, it's still very tight and very tenuous right now. So I would say over half of our patients are here with COVID, and they're in a special area and isolated to protect them and protect our staff. But yeah, our volumes and our acuity has definitely gone up. And one of the things that we've seen is that there's a downstream or upstream effect when we're in that situation. We're not the only hospital in it. So we are having a lot of patients on a regular basis that there's no place for them to go. And it's not because anybody's refusing. This is the part that everyone's been saying is coming, is coming, is coming. Well, it has been here now for a couple of weeks. We've had times where we can get somebody to a tertiary care center, and we've got times where there is no tertiary care center to send them because they don't have beds, and that's very hard to try and make sure that you're doing the best you can for those patients, knowing that you would love to have them someplace where they had additional specialists. I also say that in general, COVID has been very tough on our staff. In general, we see people get better. That's not always the ending that we've seen with COVID, and that is very wearing on the staff. So aside from physical, everything else, our staff care for patients wearing N95s in all of our care settings. And it's hard to breathe through an N95 all day. Done it. But from a safety perspective, with the COVID testing and the delay, you can be negative but still have COVID. It just hasn't shown up yet. That's been the biggest thing to help us protect our staff from contracting COVID while working. But it's been unique.
Do you as a not only a medical provider and in the role as CEO, but as a medical doctor, you are part of that hero health team that's out there working daily with patients. Does it ever concern you? I'm sure it does, but how do you, I guess maybe a better question is, how do you deal with that, knowing that you're walking amongst a disease that could literally, or virus that could literally take your life, and you do it every day and you know that it's there and it's around you? How is that, how do you handle that mentally, and how does your medical providers handle that? Because I mean, that's like basically like being in a war. I mean, you know, these bullets are coming in and you know they're right there.
So I think probably the first thing back in February of last year and early March recognized that high probability this is coming our way. And so at that time, we geared up for PPE, because I feel is without question my responsibility to protect our employees and make sure that they have the protective equipment that they need. So for us, we have done things different in that every patient is cared for wearing an N95. If somebody is suspected to have COVID or has COVID, we put our staff into a spacesuit, if you will, a PAPR, to make sure that there's no chance of misfitting, or if you've worn an N95 long enough and you're in a code or you're in another situation, even though it's supposed to fit right, and it does, it can still migrate. So our staff safety, it was paramount from the beginning. And I think with that, we've had significant trust from our staff, recognizing that I'm not going to put them in harm's way. And in fact, I'll probably make them mad doing some of the things that I'm going to do to help protect them. Mm-hmm. And I'm sure I have. So it has been challenging. Now, I would say dealing with life and death viruses and those type of things, we've done that. I've done that my whole career, not to this magnitude, but universal precautions and things like tuberculosis have existed my whole career and long before it. And it is basically the same thing, just on a much larger scale. And so one of the things that I think is getting staff to recognize, no, you don't need to put 15 masks on. You don't need to put 5 sets of gloves. You've done this your whole life. You're prepared for it. We just have to make sure we're very careful and following what we know we should be doing. And that has made a world of difference. But I would say probably our families are probably the ones that pay a bigger price, if you will, because, you know, you've got nurses coming to the hospital and their families are wondering, are they going to get sick? Are they going to get hurt? They're seeing everything on television. So I think it's probably a larger toll on healthcare workers and their families. Not to say that it's peaches and cream here and that everyone is A-okay, but trying to do things to lighten the mood, if you will, and to help let them know that we appreciate them. So it's been a struggle.
Talk a bit about your critical care staff. I know with this pandemic, has there been a need to add additional people? You're looking at around 600 employees at Sampson Regional, give or take. Do you need more people in the critical care staff? It would seem to me, although I would like to think there would be people that want to go into that profession, it's kind of a foreboding profession when you think about it. Are you up to the numbers you need? Do you need more people? Where do you stand there?
I don't think there's a hospital in the United States that would turn away people right now. And one of the hard parts with COVID is critical care is everywhere. So you've got ER and more acuity, you've got med surg and more acuity, and dealing with things that you don't necessarily always are used to dealing with, especially in the number. Is really the numbers that really is challenging for them. From a critical care nurse perspective, most certainly we could use more. And then again, there's times that from a absolute lack of bed capacity, we're caring for critical care patients in the ICU, or I'm sorry, in our ER, because we can't get them into a bed. We don't have a bed, and having them where they're monitored in the ER, and we have nursing staff there to care for them. So it's been a challenge every step of the way from an acuity perspective. And like I said earlier, wearing masks, taking things on, taking them off, it adds one more stress layer to an already stressful situation. And again, I can't underscore our staff in caring for these people. We can't be in a position of sending somebody in as a family member to get COVID from somebody with COVID that's dying. That's just not ethical. And so for a lot of our nursing staff, they're the caregiver, but they're also the soother too, which again takes a toll. So we do have counseling services available to help them, but it's definitely been a challenge for us.
We're going to take a quick break, Dr. Howerton, and we'll be back in a moment. Ladies and gentlemen, stay tuned. We're coming up on our second half. We'll be back in a moment with section 2 of the program. We're talking to Dr. Shawn Howerton about healthcare, Sampson Regional Medical Center.
Experiencing slow internet? If you have a fast internet package, the problem is most likely your wireless router. With more devices using Wi-Fi, your wireless router may not be able to deliver the speed and coverage you need. We now have the leading solution to enhance your internet experience. Using small devices in a mesh network, these Wi-Fi appliances cover just about any size home so that all your devices can operate to their fullest potential. Whole home Wi-Fi from Star Communications. Get the most out of your internet connection.
Ladies and gentlemen, welcome back. I want to thank you for being with us today. We Should Know is on there. I'm JW Simmons, your host. We're talking with Dr. Shawn Howerton, the CEO, medical doctor, CEO of Sampson Regional Medical Center. Dr. Howerton, thank you for being with us today. We're in segment 2 of the program. And in segment 2, I wanted to kind of get a perspective on Sampson Regional Medical Center and talk a bit about where it is, and you alluded to this a bit in the first segment, but in the state of the art kinds of things as it relates to hospitals. You alluded to the fact it's like we're probably in the single digits now with hospitals in rural areas like Sampson Regional. They're not able to maintain financially. Sampson Regional, according to you, is in good shape. Financially, we're in good shape as far as staff and those kinds of things. Let's talk about that from the sense of not only the staff, but the hospital and the facility itself. What are the kinds of things you would like to see happen, given the dynamic of what the future may or may not look like? I don't know if anybody could even imagine this thing called pandemic, but looking at the future and expectations from your medical world as a medical doctor and as a CEO, what would you like to see happen at Sampson Regional Medical Center?
Well, I think for us, one of the bigger things is providing some additional care things in our community that otherwise don't exist. Transportation is an issue in our community, and getting people to specialists outside of our community is a challenge. So things like recruiting neurologists, psychiatrists, rheumatologists, expanding those service lines while not directly facilities is one of our key strategic goals. Our oldest part of our hospital is 1950s. The newest is 1970s with a small addition in 1980s. And so very much an old facility, and you can maintain old facilities. But one of the things that changes over time is what the routine footprint, I guess, if you will. So old structures have 2 feet of ceiling space above the tiles, and our newer part, luckily in the 1970s they were doing this, has 7 to 10 feet above the ceiling. So our future, if we look at making any kind of facility changes, would be surrounded that section. But really, for us, we're not necessarily looking to provide services in Sampson County that we can't safely support and provide. So we don't need to compete with heart transplants and heart catheterizations. And in rural North Carolina, we are fortunate enough to have outstanding tertiary care centers in about an hour in almost every direction. So replicating that here doesn't make sense from a quality of care perspective. While there's dollars there, we chase quality care, not just dollars, and that's a balance. Obviously, we need to remain solvent, and we have. And probably one of the bigger keys is we don't spend what we don't have. So it sounds just genius, but we all do it at home. So, or hopefully we do. And so our team is very good about that. We have a very supportive board, and really focused in on the community and quality care. So if it does not make sense from a facility addition or change to improve the quality of our care, it's not something that we're looking at. Now, yes, I'd love to have brand new MRI machines, and within the next couple of years, we'll be replacing our MRI. Same thing with CAT scans. But there's parts of newer technology that changes, but usually those also require additional physician knowledge that may or may not be appropriate for our community to provide those services. So overall, everyone likes newer. I love newer, but we've been able to maintain safe care in our current facility. But I will not turn you down for a new facility if you're sending it my way.
You mentioned technology, and I think that's an area I wanted to go into is this idea of the technology expectations that has changed since the beginning of this pandemic. How has technology and the expectation of your patients changed as we've moved now, which will be almost a year or more into a pandemic? What has changed with the push forward for everything from meetings with doctors online and various other kinds of technology you guys use? What can you tell us about that happening at Sampson Regional and other technology changes that you see, and what expectation you think folks are going to have for the future?
So I think without question, the pandemic has changed how we practice medicine in the future. One of the words that I love the most and hate the most is pivoting, but everybody has had to learn to pivot. One of the things that, from a technology perspective, that very much came to light in our community when the government's saying, yep, you can do a teleconference with your patients, and as long as it's safe and secure, we don't care how you get to see them. Mm-hmm. That's wonderful. But in Sampson County, there's a lot of flip phones. There's a lot of lack of phones altogether. And trying to safely care for those patients has been a challenge. So we've had programs where we've given out tablets to be able to care for people. We see people in offices, and it's just really, it has changed the way we do things in the future from a care perspective. Now, I'll say that there are patients that absolutely love the fact that they can stop in the middle of work and have a conversation with a provider and turn around and go right back, and there's no delay, there's no travel. And there's plenty of patients that can't wait to see everybody face to face. Being stuck at home alone is very lonely for a lot of people, and not that coming to see your doctor is the highlight of your day, but there are people that is very joyful because they've had relationships there, and they know the staff's family, and so that has been a challenge. So I'll be interested to see as we roll forward if that is something that, from a rural community perspective, are we going to be in a position as an industry where we're providing tablets or those type of things, depending on the affluence of our community, to help those patients. I think the other part that we've noticed is it is way easier to give a a simple answer to a simple question, which sounds funny, but certain rashes and things you can diagnose rather quickly. And then there's just things that can't be cared for safely through a teleservice. I think that some of the technology items that I see on the forefront from a COVID perspective, and again, goes back to you have to have a smartphone for it to work, but there's a COVID test that you swab yourself, you stick it in a little device, and your phone pops up and says, you got COVID, you don't have COVID, and we've already notified the people. And that at a $30 price tag is not too shabby, but you have to have $30 to be able to pay it. So there's still parts of our community that will be out of reach for them. So.
It's interesting when I look at technology and some of the things that I see is almost like Star Wars that we wouldn't even imagine even a year ago or 2 years ago. As a medical doctor, just put your MD hat on for a minute. And you mentioned a couple of things that we just couldn't deal with as it relates to telemetry. What concerns you with things that you might not can do now with technology that you literally need to see as a doctor? I mean, you need to, I think the old saying is you need to have hands-on. What are those kinds of things? And what would you suggest to folks, and how do they get to you in a safe capacity? I talk with a lot of folks who say, look, I don't even want to go around a hospital or a medical facility because people going there have got COVID. I don't want to go there. And that's really a big challenge.
So, and to answer the first part of that question, one of my colleagues, who's a radiologist, he has a golden plaque on his desk that shows antiquated medical equipment. It's a stethoscope. Because in his world, you don't listen to the heart and lungs, you just do a CAT scan and that tells you everything you need to know. And that's not the reality. But so things that I would need to listen to your heart and lungs and really being able to look at you as a person, we definitely want to see in the office. Now, I'll say for all of our local practices, overall, I would say that they've done a very good job, even the ones that are not owned by Sampson Regional Medical Center, at making sure people are protected from COVID. For our practices, we have a variation of what we do depending on our practice. So there's practices that it makes sense that we do a video chat in the car, bring you in and see you and do your exam and then finish up that way. There's conditions where we definitely bring you in and see you. Mostly from a standpoint, not that we're afraid of caring for people with COVID in the practices, but just for what you're saying is people are terrified to come to doctors' offices for fear that the person before them was just breathing COVID in the office. So our approach is patients shouldn't come in contact with each other. They don't see each other. We bring one person in, we bring them straight to a room from their car. So that's kind of been our go-to with that. From a hospital perspective, doing screening for everybody that comes in, we've limited visitation to what we can reasonably, and then providing the loved ones and caregivers to be able to help make sure we're getting everything we need to from a history perspective from the patient and their family to be able to care for them. And from a technology perspective, can't tell you that I fully knew what ionizing devices were, but our ER building, that whole building has 3 of them that purifies every bit of air every time it comes through. So I would also tell you that I wouldn't expect that I would know how many air changes are in certain rooms, but we have them calculated so that we can make sure before somebody else goes in that they're fully cycled and cleaned even before our staff goes in. While we've things have been delayed, we've purchased additional UVC lights to clean COVID because it'll clean in the air. But I'll say that things like that are very high demand. So we're still on a waiting list waiting to receive those just like everybody else.
We're going to take our break. We're halfway through with the show. So ladies and gentlemen, if you'll stay tuned, we'll be back in a moment. I'd ask you to call a friend. Tell them we're talking with Dr. Shawn Howerton, CEO of Sampson Regional Medical Center, also a medical doctor, about things that may impact their lives.
Many things have been stolen away during this time of uncertainty. No crowds to cheer on their favorite teams. Applause and pageantry have been stripped away. Thieves are looking to make your home empty and silent. Star Communications has the answer you are looking for. Security by Star. Automation and affordability along with friendly service makes for a security choice that is sure to keep your family cheering.
Ladies and gentlemen, welcome back. We're halfway through the show, starting on our third segment here. I want to remind you, if you want to reach us, make a comment, send it to email weshouldknow.edu@gmail.com. That's weshouldknow.edu@gmail.com. Or if you want to just drop us a card or something, you do that. And that's Post Office Box 1482, Clinton, North Carolina, 28328. It's Post Office Box 1482, Clinton, North Carolina, 28328. We're talking with Dr. Shawn Howerton, CEO, medical doctor, Sampson Regional Medical Center. Dr. Howard, we've talked about a lot of stuff. I want to open this segment with a question about partnerships and affiliations. You hear that a lot with rural hospitals. Who are they affiliated with? Who are they partnered with? Can you give us an understanding of, do we have existing partners? I know we have folks that are on your campus there from UNC Rex. Which I'm very fortunate because that's one of my primary hospitals, if I have to say. But is there other affiliations, and do you have to have those mapped out over a period of time, or can you transfer to anywhere? I mean, that's kind of a world that the average people like me probably don't understand, but I think it would be helpful.
Sure. We do not have any formal affiliations with any hospital or hospital system. Patients that have emergency medical conditions have to be accepted at any tertiary care center if a bed is available. So if somebody has the ability to provide life-saving services that we can't provide, they have to accept that patient, regardless of insurance or anything else. They have to do what's right for the patient. And in general, again, tertiary care centers, they're here, they want to care for patients. That's what they do as well. So I will say that we tend to have tendencies to referral patterns, and in part with Rex Cardiology, having some local cardiologists that are in our community. We do tend to send a lot of our cardiac to Rex. I'm certain that if you had an issue, you'd be more happy if you need a service to be able to see a friendly face up there that you already know. But we're fortunate enough to have them in our community and be able to see them locally here as well. But no formal partnerships. I will say that we're continuing to work on some agreements to try and get patients elsewhere faster. So parts of that is as we look at our stroke certification and trying to get patients that need to be to a stroke center quickly. We don't need to call 3 hospitals. We need somebody that will pick up the phone and say send them, and it's a non-issue. We don't want any kind of delays with that. So we're continuing to work through a process there, but it really kind of varies on specialty where we tend to refer.
I want to segue into this whole world of COVID, and again, I alluded to you and I talked off air too about that. We talked last year about COVID during that kind of first or second trimester of the COVID event on the calendar, but we're now in a different place. And when I look at COVID, I'm looking at a number of things that we didn't really get that much into, which was the vaccinations, because there was none. We didn't get that much into tracing and tracking and those kinds of issues. A lot of that's been farmed out, it seems, to local health departments and those kinds of things. What is the role? What do you see the role of, or what should the role of a local rural hospital be in the administration and of vaccines, testing and tracing and all that kind of thing? It's folks are confused. I don't think they really understand that, because when you get into Research Triangle area, you got Duke, UNC, you got a number throughout the state of major hospital structures that's providing that. But in the rural areas, it's like the overwhelming responsibility fell on the local health department.
Well, and exactly so for us, we view our role in our community as we're not for profit. We are here to better the health of the community, and no better time for us to dive right in than in the pandemic. So, um, the health departments, there's only so much that they can do from a staffing, funding, and so our local has dived right in and provided services. But one of the challenges definitely for them, you talk about tracing.
Mhm.
Well, tracing is very easy if you've got two people that you need to trace. But when you start tracing 100 a day, and then the 100 people that they came in contact, and then the other 100, and it is just overwhelming the amount of that reach. So the health department is funded through the state and federal government. So that is their role is to help improve the health of the community. And our roles are not competing. We work very well with the health department and work in tandem with them. So they have been doing testing. We've been doing testing. Uh, we both have hit some hiccups with trying to get out vaccines as fast as we can.
Mhm.
While we see a lot of things on television, one of the struggles that we've had is that um, in our state, the rules have changed several times as to who gets the vaccine. So we are now on it's a federal vaccine by federal rules. You don't have, it's not based on your county, your state, or your citizenship. Um, so initially, our direction was these are the vaccines for your community based on population. And so, bit of a struggle. I think one of the other thing from an operational perspective is trying to get them out as fast as we can, but you have to be able to plan and to be able to plan to do it safely. And if you kind of think about it for planning a birthday party, um, so I'm not going to tell you that the event's available. I'm not going to tell you how many chairs you have at the table or cake that you can have
Yeah.
until the day before.
Mhm.
And I need you to make sure that all that cake is gone and everything's cleaned up. And you need to plan for another party next week. Well, which day? So that has been a struggle for, I think, a lot of us trying to make those plans. And the initial, we don't know when we're going to get more. I would say, without a doubt, a lot has changed within the last week, and we have the opportunity now to increase our the amount of vaccine that we can receive. And overall, we've done a good job of making sure that once we get vaccine, it's gone. So as of Monday, we had no vaccine for first doses and about 300 for second doses. And our new shipment came in, and we've already decremented, and those will all be gone by Friday. But for us, that's about 400 first doses that we'll give in 2 days. So we can ramp up if we know that our volume is going to continue. And while there's the opportunity technically to bill somebody for the act of injecting the vaccine, from our community perspective, we're here to serve the community. We're not for profit. We're not charging people to receive a vaccine. Um, for us, that is part of our services to the community, and there's a lot of expense to it. But every person that I get vaccinated is one less person coming through the ER, which is one less burden on our nursing staff and our physicians. So the more that we can get vaccinated, the quicker this all ends. So that is really our goal. And again, working with the health department, we've worked in tandem and worked very well to try these vaccines out.
One of the things that, and this is kind of an analytics question, I've noticed in some parts of the state, they approach this strategically as an appointment basis kind of thing. And you get an appointment, you go get your first dose, you schedule then your second appointment, and whatever period of time that is, depending on which, whether it's Moderna or Pfizer, you get your appointment to take your second dose. And it seems to be very orderly, very well done. Then other parts of the state have drive-ins in which you have people, I've heard people saying they've waited as much as 6-8 hours. From a practical point of view, it would just seem the appointment thing seems to work well, but then maybe not. talk to us about the analytics. I get a lot of folks saying to me, looks like they would do this, or why would somebody have to wait? So help us understand that.
Sure. I think one of the biggest challenges with the vaccine is, while everyone can say they've had a flu vaccine before, you can't say you've had a COVID vaccine. Mm-hmm. So especially initially is having a comfort on how people are going to do post-vaccine. So for us, wanting to be very orderly, and again, making sure that people are comfortable coming to get their vaccine and not worried about that they're going to get COVID while they're there to get the COVID vaccine, we immediately launched an online scheduler where people can schedule their appointments, and then they come to across the office, and we provide them their vaccine. One of our challenges with that, again, is I need to have vaccine in hand before I can open up appointments, if you will, for next week, mm-hmm. because I don't want to let 300 to 400 people down that they've changed their plans to come get a vaccine and not be able to deliver. So I think as we have a greater comfort that we're going to receive the vaccines that we're needing, I think that we can ramp that up, and we've talked actually even ramping it up over the weekend and with some dedicated staff. So I think we've been able to manage that pretty consistently without a bunch of additional resources as far as is needing to do police and those type of things and be pretty orderly. While a drive-through, and I'm definitely not saying that we won't move to that at some point, a drive-through is wonderful for a large volume. Logistically, it tends to clog the highways and those type of things, and you need a lot more people to vaccinate. Especially initially, not knowing how people are going to fare, we need to be very cautious because we have to watch people for 15 minutes.
And not to mention, it's not that good on the people trying to get that shot either. So when we come back from break, I want to kind of get into this last segment and to some kind of other kinds of details and continue the conversation about the pandemic. So ladies and gentlemen, if you'll stay tuned, we'll be back in a moment. Dr. Shawn Howerton, CEO, Sampson Regional Medical Center, also a medical doctor here in Sampson.
To get the most out of your electronic devices, you need a strong internet connection and a protected home Wi-Fi network. You need high-speed internet from Star. Star has the fastest, most affordable high-speed internet service available for all your devices. We have no long-term contracts or high-pressure sales. Our service speaks for itself, and switching is hassle-free. We take care of everything with free installation from a local company. High-speed internet from Star. Internet at the speed of life.
Welcome back. Coming up on the last segment here of We Should Know, I'm your host, JW Simmons, and the guest today is Dr. Shawn Howerton. Dr. Howerton has been CEO, I believe I remember reading, since 2014, Sampson Regional Medical Center. You stepped into that world as well as maintaining a private practice in Roseboro.
Yes. So I stepped into an interim capacity in November of 2013, and June of 2014 was official. Pleased to be here, pleased to be able to help care for the community.
Needless to say, it seems to me you're a guy that likes challenges. That is probably true, and may fall under that character fault side at times. But yes, I like a challenge. I don't believe anything's impossible. So that could be an understatement. I'm not sure. I want to kind of get into the world we're in now as it relates not only to the pandemic, but to the hospital and to a lot of things you do with the medical world. We're into a new administration on the federal level, and we all have seen a huge number of executive orders going out over the past hours and days. When you look at where we are, and I know you look at it from the sense of the impact for the hospital and the impact for medicine, we've heard conversations from the new administration and those that are associated with it of a program called Medicare for All. We obviously, I think we'll see a continuation of Obamacare. When you hear those kinds of things, Dr. Howerton, as an administrator and somebody that looks at the bottom line, what does that say to you, and in a sense of what the finances may be that you have to live with?
I think that as they say, the devil's always in the details. I would tell you that for the last decade, healthcare has changed exponentially, and the future of healthcare is going to be continue to do more with less. But there is a point in time that more with less can't be done safely. So I think one of the probably overarching themes is talking to my peers. If we could have one set of rules, one game plan, and again, whether that's Medicare for all, whether that's universal health care, whatever we call it, um, we can set up a budget around it and work with it as long as it pays the bills. So if you can't keep a hospital afloat on Medicare dollars and you're only receiving Medicare dollars, then that's going to significantly impact the goods and services that hospitals can provide to their community and whether they can stay open. That is probably one of my fears as we look at that. It tends to the rural hospitals tend to be left out of the equation in the conversation until there's discussion about how underserved rural communities are and how unhealthy rural communities are. Mm-hmm. It's a challenge to see the dollars arriving here to through some of those programs. But again, the devil's in the details of what they are, and if we as a hospital system can be reimbursed fairly and be able to keep a margin and keep our doors open, we're willing to look at anything twice.
The North Carolina Hospital Association has looked at a number of areas that they see as a concern for 2021, and one of those is something called a balance between dealing with surprise billing. Mm-hmm. Another one is tax treatment and preservation. Any of those that you would like to speak to that would be particularly a concern for rural hospital?
Sure. I think probably one of the bigger challenges for everybody is quote unquote surprise billing. Nobody likes surprise billing, not the patients, and surely the hospital doesn't either. I think it kind of shines a light on the complexity of insurance, and I could bore you to tears for hours about all the background of how our system works, but it is a very broken, goofy system, if you will. Everybody that provides care in a hospital is not employed by that hospital. So that's where it starts to get challenging. So you can have a doctor providing care within the hospital that doesn't accept a patient's insurance. The hospital accepts it, but the provider doesn't. And then they're going to receive a surprise bill from that provider, not necessarily the hospital. So for us, one of the things that we do for any of the providers that are contracted with us, we require them to participate in any insurance that the hospital participates to help decrease that. But I will say that is an ongoing challenge. The other part that most people don't recognize is a lot of insurance is regional. So I've got insurance, hospital provides me insurance. Now, the moment I leave our community and I'm over in Georgia, or if I'm up in Ohio, depending on the network that my insurance has, I may be in network, I may not. If I'm not in network, I pay a significantly higher deductible. And again, not necessarily my fault that I didn't choose a hospital in my local network or a provider in my network. People don't choose to have their emergencies. So that's an area that I think the Hospital Association and we very much support trying to come to an end of that. But the hardest part is as you peel back the layers of onion, it becomes more and more challenging and problematic, and you start digging into, again, a lot of rabbit holes of how everything works and stacks on each other to keep this house of cards of insurances afloat, if you will.
And I think that gets to a conversation. In fact, last year I had with the North Carolina Hospital Association, and then I had a conversation on this program with Treasurer Dale Falwell. And one of his mantras was, well, we need to standardize. If you get a certain procedure at Hospital A, then Hospital B, it should cost the same thing. Help us understand why oftentimes that's not possible.
Well, I think parts of it are possible, but I think the reality is that there's different cost structures based on every organization. So, um, and the other reality is everybody's contracts with every insurance is different. So one of the things that frequently hear, and I'm sure you've heard it a zillion times, is, "Oh my gosh, I got my bill from the hospital, and an aspirin costs $400. How
Mhm.
can that? How can that be possible? That they're greedy? That?" But the reality is, um, if you tie all these together and you think of it from a bigger picture, for hospitals to get cost of living increases, so from our insurance companies, so let's just say that we get 2 or 3% increase in reimbursement for our charges in 2021 compared to 2020. Um, for us to get that increase, um, we are required to increase our charges. If we don't increase our charges, then we don't get that 2 or 3%. Now, that's not things that you see publicly, and I've not seen it otherwise very well documented. But that, if you look at that and you take that over 10 years, your pricing just went up 20%. Why? So that you could get the 20% increase that you're otherwise owed by an insurance company. Uh, that's where all of this starts to stem from, that those prices escalating. Not that the patient technically usually pays those, except for when you're out of network, or you're uninsured. So that system, again, very broken, is a system that hurts the uninsured, underinsured. Now, we have very robust charity care program that goes up to 250% of poverty for our community to be able to provide care to them, but it is still a challenge with that whole system. And so, hospitals don't like increasing their charges, but again, to be able to get the offset increase from insurance companies, we have to do that. And if you think about it from the other side, if I'm selling you your business, if I'm an insurance company, I'm selling you that I'm going to give you a 55% discount over what this hospital is charging. So if that decreases, now it's 52%. Now it's 49%, 48%, and eventually we'd be in the perfect spot of here's what your charges are and here's what you're getting paid.
Yeah.
But again, when that happens, as a business, you're going to say, why am I paying for insurance if I'm going to get what the rate is? So again, that's about this level of detail in the whole system. But all of that thrown into a blender is kind of where we live in healthcare right now.
That a couple other things that struck me is the whole conversation about transparency as it relates to healthcare, and it's part of you've already answered that, I think, but it kind of seems to me from a outside looking in point of view is folks just want to make sure that if they get a pound of whatever, it's a pound of that's the same thing. I mean, it's service for quality and content, but you can't just look at one item and say, I would say even probably, I don't know, but I'm guessing even an X-ray or an MRI, one may not be the same somewhere else, but there may be other factors, I guess, that what I'm trying to say involved in
Well,
that.
and one of the things with a couple points with that. So first is and we run into this with insurance companies. You came here for a preventative, let's just say colonoscopy, covered by your insurance. When our doctor goes in, or the doctor goes in, and they find cancer, they find polyps. It's no longer coded as a screening colonoscopy. It is now a cancer, or it's a colonoscopy with polyps removal, which is not covered by your insurance plan. So where I can tell you the price of your colonoscopy may not just be a colonoscopy. Your colonoscopy may be this or that, or other bad things. So it is a challenge. I think probably hospitals' bigger concern with that is just putting out all your pricing for insurance companies to compare and level what they're doing.
And to that point, it just manifests into something else that is again a different cost factor. I want to thank you for being with us today. It seems like every time I have you on, it just goes by fast, and it's because we have so many issues that that need to be explained. But thank you for being with us, and we look forward to having you again. Ladies and gentlemen, thank you for being here today, and we look forward to seeing you again next week. And we always look at you and say, may God bless.
Thank you for tuning in to this week's episode of We Should Know with host JW Simmons. If you have a question, comment, or suggestion regarding this or any episode, please send your emails to weshouldknowedu@gmail.com. And remember to tune in every Tuesday at 2:30 for another informative episode of We Should Know.